Good morning. My name is Dominic Schofield. I'm the president of the Global Alliance for Improved Nutrition in Canada and a senior technical advisor for GAIN's global programs. In this session, we're going to be looking at behavior change interventions to address health and nutritional needs of adolescents. At GAIN, Global Alliance for Improved Nutrition, we of course were created to focus on addressing malnutrition and improving nutrition globally, but recognize more than ever in the era of the Sustainable Development Goals that this is not possible if we don't break boundaries and barriers down between various disciplines and development agendas. And so we've been pursuing the integration of nutrition in development programming, but also in the activities of the private sector, looking at how markets play a role to do the same. Our headquarters are based in Geneva, Switzerland. We were founded at the second session of the UN General Assembly focused on children in 2002, but have since become independent and are working currently in about 40 countries, supporting programs in about 40 countries, with offices in about 12. And the way we do our work is to build partner platforms between multiple stakeholders, usually government, civil society, and the private sector, to pool resources, to create ways of shared thinking, really to address some of the most intractable problems related to addressing malnutrition. We also do this in a way that focuses on what we can do to take things to scale and sustain that scale. And so this is one of the main reasons why we are so interested in looking at not only public delivered approaches, not only community development, but those two, as well as understanding how markets work to serve the poor, recognizing that the people that we are trying to serve are not just beneficiaries, but are consumers, are individuals making decisions that as much as need good programming to meet their needs, to support their needs, also need to be mobilized and engaged in that programming. We also take a life cycle approach to this, and so it's sort of a three-dimensional beast that looks at intervention approaches like large-scale food fortification, or target groups like infants, young children, and their mothers, or sectoral-based approaches where we look at agricultural value chains and see how to improve the nutritional quality of those value chains. These three different sorts of approaches that render us a bit of a three-dimensional organization really do come together when we are working at the country level. It's really the context we are seeing over and over again that drives the design of the programs that we support, the partners that we work with. And so while we began about 10 years ago our work around infants and young children, we too have seen the importance of the second window of opportunity, particularly of adolescent girls, recognizing that the saddest irony is that while the pivot to breaking the cycle of malnutrition and indeed poverty are adolescent girls, they are often the most marginalized in their communities, in their households, the least likely to be able to make decisions about their own bodies, let alone the food that they eat when they get to go to a health center. So some of the experiences that will be shared today on this panel will be really to look at addressing the needs of adolescents, both from the perspective of programming, but also thinking about innovative ways to mobilize that population. And so I'm really very happy to be here. I am grateful to the organizers and Global Affairs Canada for hosting this meeting. And I'm privileged to introduce to you our three esteemed panelists. Laura Reichenbach, who's Senior Associate and Deputy Director of Research at the Population Council for the Evidence Project. She'll be speaking about adolescent-friendly health corners. Dr. Bridget Idam, Senior Research and Evaluation Advisor at World Vision International, will be looking at the role of grandmothers in the ecosystem driving change for adolescents. And Dr. Mandana Rabi, who is the Director of the Business Platform for Nutrition Research at GAIN, will be looking at social media platforms and how those have been used in Bangladesh and Indonesia. And so to begin, I'd like to hand over to Laura to give just a few punchy first words about the work that she's been doing. I'll ask the other panelists to do the same. And then we'll get into a bit of a conversation, perhaps provocative. I'll ask some questions. And then we'll move on to interact with you and get some of your questions on the floor challenging our panelists. Is that okay? All right. No need to clap. Thanks, Katie. All right, Laura, over to you.
Great. Thank you, Dominic. I'll do my best to be punchy. I have just a few minutes to share some reflections on an assessment that the Evidence Project just recently completed looking at adolescent-friendly health corners in Bangladesh. And I just want to start with a picture to give you a sense of who these adolescent girls are. I'm sure many of you are well aware. But the roughly 27 million of the population in Bangladesh are 10 to 19-year-old adolescent boys and girls. And so they really are the future of the country. We've heard a lot this morning about the importance of the demographic dividend of serving them. But what I want to talk about today is within those adolescents, the needs for unmarried adolescent girls and the fact that the health services that they need have not been available to them from the government until recently. And one of the reasons why this is an untapped group in terms of service is the social stigma associated with seeking services related to SRH or family planning. So next slide. So the government of Bangladesh, with the support of development partners, has recently tried an approach to address this gap in order to reach unmarried adolescent boys and girls for the first time. So this is really, really an important opportunity for reaching adolescents who otherwise may not have access to services. They're doing this through specially designed adolescent-friendly health corners. They are not standalone youth services. They're a part of an existing public sector hospital, a maternal and child health hospital that's been adapted specifically to serve unmarried adolescents. So they're built into the existing system. They are staffed by providers who are provided special training in adolescent-friendly health services. I don't know if you can see the description. There's a whole range of services. It's not just SRHR. It includes nutrition counseling. It includes a whole wide range of services. So the government of Bangladesh and USAID asked the Evidence Project to do an early rapid assessment of this approach to inform the government's replication and scale up. And I just want to say, listening to the data session this morning that was really so interesting, what we did was not a quantitative survey. There's a lot of quantitative data that exists in countries like Bangladesh. What we did was we went to the youth themselves. We did rapid, in-depth interviews. We did a quick turnaround in terms of analysis. We talked to service providers. We talked to parents. And then we disseminated it to the government, the development partners. And I think that's another piece of the data that can be really helpful in terms of particularly making mid-course corrections. Just very quickly to say that the unmarried girls are using the services. They've definitely had some very specific suggestions for changes to be made to improve those services. And I would just end, because I think I'm running out of time here, but I'd be happy to share some of the specific findings in the question and answer. I think what we found, both in the interaction with stakeholders in the dissemination and in talking to the service providers and the adolescent girls, that this is really a unique opportunity to rebrand these services so that they're not just seen as family planning SRHR. It's really being seen as an information hub, that when you talk to these youth, they are keen for information about a whole range of things, from substance abuse to mental health to domestic violence to family planning. So I think I will stop there.
Thanks, Laura. Just a quick question. This report that you're showing us here, this was intended primarily to influence governments, donor agencies, the development partners, but it was a rapid assessment. Can you tell us a little bit about how it's being used or what the response has been to the report?
Sure, yeah. So we just had the dissemination a couple of weeks ago, and The response was very positive in the sense that both the government, the Directorate General of Family Planning, but also USAID, UNICEF, UNFPA, and some of the other implementing partners found it very useful in terms of some of the specific suggestions about what's not working, what types of things need to be changed. So in that sense, it's I think, quite positive. And the government of Bangladesh in their next 5-year operational plan is planning on scaling this up. So.
All right, well, thank you very much. I'm going to shift over to you now, Mandana. Speak a little bit about what GAIN has been doing in Indonesia and Bangladesh, please.
Sure, thank you very much, Dominic. So basically, GAIN, of course, is involved in nutrition programming, mostly targeted at vulnerable populations in developing countries. And around the issue of nutritional challenges of adolescents, like all of you present here, we are very cognizant that this is a problem and it's very critically important. Now is time for action. But also increasingly, the issues that we need to pay attention to are the fact that determinants of problems, even in developing countries that maybe have similar socioeconomic status or other pictures, are quite different. I put this graph here for you to see that, across these 4 developing countries that we have put here, we have different burdens of different nutrition problems. You may see a country that has, in the same age group, both anemia and thinness, wasting. There may be another country that is suffering from overweight and obesity in women at the same time that has a burden for undernutrition. So this just is an example of how we need to be very context-specific in coming up with programs or ways that we want to address nutrition issues in adolescents. And then to show you 2, in a way, contrasting examples of how this can be done, this is an example of GAIN's formative work in Indonesia, where we found out that, for example, adolescents do have some purchase power. They do receive pocket money from their families, and they do spend money on buying foods outside the home. But at the same time, they're facing the competing market forces and the fact that there are a lot of cheaper snacking options that really influence their food choices. We use the social media as a very powerful platform in Indonesia to engage the youth. And this, in a way, was also a test for us to see whether, with all the things we hear about social media and how young people are engaged in social media, do we really see this as a viable platform for engaging the youth in health and nutrition? This was just a social media campaign asking the youth to come up with an equivalent kind of a tagline for how you can encourage your peers to reduce intake of unhealthy foods. And almost within a month of the campaign being online, we had about 1.5 million participants. So for us, as a first step in addressing large-scale intervention programming, this is at least a sign that, yes, social media is a viable platform. We really have to build on the massive power of social media. And then the other thing is, in a different country, for example, in the context of Bangladesh, when we worked on formative assessment of what adolescent women especially deal with, how do they make their food choices, what could help them have better choices and more options for healthier foods. Here, the issues were the fact that they actually don't have a lot of decision-making power within the household. So for example, a campaign or behavior change intervention that would only target them without empowering and enabling them within the household's decision-making probably wouldn't be very, very successful. You would also need to engage perhaps the other adults in the household, the husbands, the grandmothers, the mothers-in-law. So this is an example of how the contexts vary, and you would only be successful if you can actually understand those drivers and build your programs addressing those. As a take-home message, I just want to also say that, I heard and I saw from the agenda of these 2 days that this is about really comprehensive look at how we can improve the situation for adolescent health, and that's amazing. But from my perspective as a nutritionist, having been involved in developing country programming, I think this is not just about integration as a matter of convenience or efficiency. This is actually as a matter of science and evidence and almost a human right. I think we cannot cannot talk about improving nutrition without talking about adolescent reproductive health access, birth spacing, delaying first pregnancy, and other issues that really affect how young people enter adulthood, and also how their mothers, how young women enter parent motherhood, because they need to have nutritional resources and the preparation to be part of the healthier future life for themselves and for their children. So I would like to just again call for really all of us to think about integration and how we can think about a package of interventions that would have elements of different things that have been shown to work.
So Mandana, listening to what Laura was saying about adolescent-friendly health corners, very health system-oriented, how is what we're learning in Bangladesh and Indonesia using social marketing platforms in that context relate to?
Well, for me, it was actually really enlightening just hearing about the fact that, this is a reproductive health targeted at young women in Bangladesh that seems to have acceptability. And I think in this context, that itself is actually really important, an important achievement for families to have trusted the system enough to let the young people to go for counseling and access to services. And right there, that's an opening for providing nutritional interventions that are appropriate to the context through the same mechanism. Of course, having worked at the country level, I know it's not easy because you really have to have a lot of elements in place to be able to deliver and implement together. But as I said, to me, this is an imperative, and it's the ethical obligation and scientific obligation, and just beyond efficiency matters.
Thanks for that. Bridget, I understand that you've got a film for us as well, so that's great. If you could make some opening remarks about that.
Yeah, before I start the film, I just want to let you know that World Vision works in about 60 countries to improve health and nutrition, and we use multi-sectoral approach to addressing root causes of nutrition. However, today my focus is on unleashing the power of another generation that we haven't talked about, grandmothers, okay? So in collectivist societies, grandmothers play an integral role in caring for girls, children, mothers, and so on. We often view them as antagonists or propagating harmful behaviors. However, we can possibly harness the power that they have in influencing behaviors to improve nutrition among adolescents. They are cultural custodians, and if positively harnessed, their power can help improve and build girls' life and health. And the fact that they are concerned about girls not getting pregnant outside marriage and wanting to make sure that they are well fed makes them allies in this case. Let's go along to Sierra Leone and see how we tested a grandmother inclusive approach, and how it played out. Just bear in mind the roles that the grandmothers are playing in this contest, and also look at how young the girls are or the women are. In Sierra Leone, the context in which this video was shot and the project was implemented, Southern Sierra Leone has about 33% of adolescents who are either pregnant or have had their first child. 15 to 19-year-olds, 33% already are pregnant or have their first child. They need these grandmothers to help support them to ensure that the good nutrition is passed on, not just for them, and then passed on to the generations to break the cycle of malnutrition. Thank you.
Do we have sound?
Sanya mamana nyame anga kia ombupela mwama mehe yi mwama kuime salahi sata yentenga ho nyame anga ndenga ho wogba ti amugbendi groma ndama tile mailo mama kotuko.
Mamanieva is a World Vision Operations Research project that is implemented in collaboration with Emory University, the NGO called the Grandmother Project, and the Ministry of Health of Sierra Leone.
The central element of the grandmother inclusive approach is recognizing the role and experience of grandmothers and involving them actively in programs to promote the nutrition, health, well-being of women and children. The major innovation in this approach is viewing them as a resource rather than an obstacle. We see them as part of the solution.
Muhammad lahi to kunyanga liver clinic yu Muhammad lahi to mehe yekwe meleva denga mabe hala nyini evi kendelo no sima nga kana ga mupema enta jile ndu mundu itale mahala nyini evu fa apendo poje hala nyini evu ngali oga tenga osto ost nga gunga mamesa ga asaga mutumbu nga anina ko tu gutu ko bongengele kungo mama be pe project jinu
mo nyine hala nyini na tande o te mo fire kesana mo ya fire jile manduli ka mo fia gwe.
What communities provide is sufficient to ensure good nutrition for mothers and for their babies. If they have the knowledge, if traditional beliefs and practices are transformed to ensure that they promote nutrition of mothers and babies.
We see significantly greater empowerment among our grandmothers in the communities, and we also see significantly greater improvements in our grandmothers' knowledge about maternal and child nutrition and the optimal practices needed to ensure good health, and also much better attitudes towards these optimal practices.
We want to see that the project, spread in other communities based on the successes we are getting.
So most Mamanieva, the project is in Ottawa. The strongest say well Mamanieva ke wo vision be.
Yeah, to walk you through the approach, the steps that we use in implementing the approach are 5 mainly. It builds on formative research. So in the formative research, apart from quantitative data collection, you actually collect qualitative data on the role of different players within the community. And then you implement by affirming grandmothers. So grandmothers play many roles. You acknowledge the roles that they play, and then we have what we call praise sessions. They come and then we praise them for what they do, for caring for the girls, adolescents, and everything. Then we build on the consensus by dialoguing. So instead of messaging, that as is done in most of the community health worker programming, this is actually a dialogue where reflection, problem solving, adult education methodologies are used, to build a consensus around the issue or the problem. When it comes to early childhood marriage and stuff like that, grandmothers can't be propagators of such behavior because they don't want the girls to get pregnant. But if you talk about the issues and the situation, well, they understand some of the harm that can be to the children, then they are more likely to change their perceptions. Then we build capacity of grandmother leaders. But before that, there's also encouragement of intergenerational discussions, having forums and so on in the communities where people come together and talk about the issues. And the grandmothers who become leaders now lead social networks, and they tend to carry out a collective responsibility for the girls. And so they are now custodians of these girls, taking care of them and so on. Lastly, you evaluate the results and then you share for learning. But one main difference in the data collection aspect also is that you have a whole section of the data collection dedicated to grandmothers. So we collect information on grandmothers' knowledge and attitudes, and then at end line, we evaluate the change that has been able to achieve based on this approach. There's more information on our website for you to check out.
Thanks very much, Bridget. And so you're really speaking about an innovative way of integrating the work that we might do around mobilizing adolescent girls through the ecosystem that they're living in. A lot of the footage in the movie seemed to be focused on infant young child nutrition practices and promoting those good practices. Do you have any experience with this program at interacting with adolescent girls before they're pregnant? And are you engaging with the grandmother scheme to do that?
So for this particular project, that was not a focus, but World Vision does have programs in education, with child protection and so on, to ensure that adolescent girls stay in school and that they are not forced into early marriages and so on. And then they are not, we reduce GBV. In Senegal, for instance, we have used the same approach to prevent early marriage, and we were able to reduce age at which the girls get married. Also, we were able to reduce FGM, the practice of FGM in Senegal, using the same approach. This proof of concept study did not focus on adolescents only, but it was mainly women of reproductive age, starting from 18 years actually. So I analyzed the data. If you could go to the next.
Would you mind if I just hold you on that answer? I'll come back to you, Bridget, because I'd like to switch over to Laura for a second.
Yeah, I'll show you some data later about what we found when we break down from all the study population to young women to adolescents.
Laura, you were speaking about how you mobilize a very structured environment, through the health system. And Bridget is talking about how in the community you can mobilize key actors. How do you see the two coming together? We've been speaking a lot about a supply side approach, but what about the demand side? Can you speak to that a little bit?
Yeah, no, I think that's one of the things that we came out of our findings, is that there's a huge need for demand generation and awareness creation, and beyond just the group you're trying to reach. So not just going to the adolescent girls, but going to the parents, going to the community gatekeepers, leveraging the really strong community support groups or community group systems that exist in a place like Bangladesh. So I think finding those kinds of entry points, and that is something that came out at the dissemination meeting, and I think it's something that the government and the development partners heard. I think the other piece of this is that the services that in Bangladesh are not just for unmarried girls, they're also for boys. But what we found was the boys really aren't going. The few boys that are going are going for general health services. They're typically not going for SRH services. So I think there's a whole need around awareness generation and creation amongst boys and getting them in at an early age as well.
Mandana, do you have a few points to add to that? I think in an earlier conversation you mentioned that the images that are most frequently passed through social media are about food.
Yeah, the most shared photographs in young people, and that's regardless of gender, are pictures of food. So for me, that's a sign that young people do care about what they eat. They actually get excited about different kinds of food, and they share that. Again, it's one of those things that we should build on. One thing also that Bridget mentioned that I liked was in some cases, it's not about developing new interventions for adults or adolescents, for young people, but to really find new channels to reach to them, because they think differently. They listen to different people. They listen to their peers more probably than to their parents at some point. So it's more about, even it could be the same intervention, let's say multiple micronutrient supplementation or something that's proven and it's available in the system. But we need to find a way to actually encourage the youth to go for it and create the demand with them. So take advantage of the channels that appeal to them more, without thinking that we have to come up necessarily with new intervention areas as well.
Thanks for that. I'm wondering if we can switch back to the slides for a moment, because Bridget, you were about to mention some of your findings, and I think it's worthwhile highlighting these, but if you could just pull out the highlights for us so that we can get on to another question that I have just after that.
Okay. Yeah. So in the population that we had in this research, with a mean age of about 26 years, we found that over 90% of them in the intervention group achieved non-diet diversity, increased their amount of food consumed during pregnancy, or increased frequency of food during pregnancy. When we look at the subsample of 18 to 24 years, the younger women, we see that the effect is more pronounced. So almost 100% of them for two of the indicators, and one of them, all of them actually meet it, versus half of them meeting it in the control or comparison group. Now, all of these contributes to improved child outcomes, birth outcomes. However, a subsample of adolescent girls, limiting the sample to adolescent girls alone, you see the impact. It's huge, about 75 percentage points difference between intervention group members where we had the grandmother inclusive approach versus in the area where we didn't have the grandmother inclusive approach. So if grandmothers have so much influence and power ensuring that adolescent girls who get pregnant are getting well fed and so on, they would have better birth outcomes, which is one of the main concerns for us in terms of breaking the cycle of malnutrition. And you can see the mean birth weight in the intervention area was much higher than the comparison group.
And so, as we consider, again, the important impacts that can be achieved if we target particular populations, and if we, again, work in context with individuals in the ecosystem, what does this mean, Laura, for service providers?
Yeah, I think that because we also interviewed service providers who were trained to provide the adolescent-friendly health corner services, and I think what we heard was they suffered the same frustrations of the limitations of the health system. I think it was a little bit more microscope on those issues, so things like shortage of medicines. But in addition to that, and workload, lack of human resources, but in addition to that was the being torn between being in the health corner, but then also having their traditional married women and newborns and children who were being serviced in another part of the facility. So I think and also the need, they also expressed a real need for support through BCC materials on a range of issues that some of which they're not used to talking about. So I think it's really important to listen to to think about what the service providers need in this kind of setting.
So we're looking at I guess a publicly managed system that engages with a particular target group, and you mentioned that young men aren't participating as readily or as easily as young women are. And then we look at how we work through specific agents of change at the community level, and how that intersects with a whole range of development issues that we're trying to address. And then Mandana, you in a sense, I guess, in Indonesia, we're testing a platform for engagement. And in the case of Bangladesh, really just trying to understand, what can you do when young women are so disempowered, when the power is missing in the equation. So from your perspective, Mandana, what's next? What are the next steps that need to be taken as, of course, we fill data gaps, as we learn from these kind of ring-fenced projects that help us to understand the dynamics that we're working with? How do we go to scale, and how do we sustain that?
Well, in a way, the challenge is that we have to do different things similar to the pathway for programming that you showed. We have to move the different levels of these pathways at the same time. So, we are in a field that actually on one side, we still have to develop the science better to find out really what are the interventions that work and make a difference. At the same time that we find platforms for those interventions that we will identify and kind of recommend eventually. And also platforms for collaborating and integrating different areas of intervention. So this would be really the main challenge and the main area for focus in my mind. Not to wait for one, rather, before we develop the other. I think we have to move these three at the same time to think about implementation for adolescents and targeting them and how to reach them, at the same time as we are developing our science, making sure we have the best data and indicators and interventions. And that's the balance between, I would say, the discovery and delivery, or the implementation science and the basic science that has to move at the same time, I think, for this population group. And we have a short window, we have just a few years to intervene before they enter adulthood, and we have to make sure that we reach them during that window through different channels. And beyond health, it could be through also schools, other areas where young people can be reached.
Well, thanks for that. And I'd like to just ask you to join me in thanking our panelists and describing the work that they're doing. And I'd like to open for questions from the floor, if you have any.
I'm Johannes Paulus. I'm originally from Cameroon. And so my question is to anyone in the panel. When you talk about nutrition, and especially with focus on adolescents, what are some of the challenges which you've come regarding, overcoming climate change, which I think has a huge impact in food production and food security? So, thank you.
Who are you directing that question to? Or are you asking panelists?
Maybe the lady with the World Vision. Yes.
Bridget, you're up first. How are you integrating the work that you're doing into broader agendas like climate change?
World Vision has programs that deals with food security, resilience and livelihoods and so on. And of course, climate change plays an integral role in ensuring whether you are able to grow food and then sustain the population. We have different techniques that we engage in areas where, for instance, in the Sahel area where we don't have enough arable land and so on, there are different irrigation techniques that are employed and so on to ensure that we have food that is grown and people have access to the food at their home. And so household diet diversity is one of the indicators that we will follow, as part of our resilience and food livelihood programs. So we work in several sectors. As I said, we work to address multisectorally to address the root causes of malnutrition, and climate change is something that affects or influences access to food. And so it's a concern. There's more advocacy and stuff, but we don't work directly in climate change.
Well, I mean, it's a really important question, obviously. We found in our own programming, of course, that women and children are often already so vulnerable in a stable setting, and when you add to that response to environmental pressures and some of the conflict that accompanies that, they're so much more vulnerable. And when we look at the 5 largest economies and largest populations in Africa, Egypt, South Africa, Nigeria, DRC, Ethiopia, they're all going through the same process. They have huge populations, but mostly young. And they're facing many of the pressures that you're describing, and what we're seeing there is conflict. But we're also seeing, on the hopeful side, much more interest in investing in entrepreneurship, in livelihoods that are generated at smaller scale, but that can add value to traditional sectors like agriculture. So I think that there are a range of responses, but really looking at this in a more integrated way is what's necessary, which is, I think, what you're saying, Bridget. We're just going to cross the room over there.
Hi, Alison Riddle with the University of Ottawa. My question is for Dr. Reichenbach. When I've looked at youth-friendly services, and only very peripherally, one of the challenges that kept coming up, at least for adolescent girls, was that there was a lack of privacy when they tried to access it, especially through the existing health system, and that acted as a deterrent. And a lot of it came down to just not having the physical infrastructure to allow for privacy. And so I was curious about what came out in your study about that and how people are possibly working around that. And also just to say, the point on adolescent boys, I've also found, when we interviewed adolescent boys about uptake of youth-friendly services in Uganda, this was related to malaria though, they all said, what youth-friendly services? Mm-hmm. Thank you.
Yeah, thanks. That's a really great question. That is one of so we looked across in different districts. So we saw a range of the way the adolescent-friendly health corners were actually implemented, and there were places where they did not actually have the physical space to do it properly. And so in those, the adolescent said, yeah, there is no privacy. And so actually they were actually being serviced elsewhere in the facility, as it turned out. So I think that is a huge issue. I think and again, it goes back to what we were talking about earlier, is being realistic about what are the resources required for this. And, we talked about sustainability. I think that's the next thing. They're talking about replication and scale up, and my understanding is Plan International is part of that in a division of Bangladesh over the next 4 years, and I think it'll be really interesting to hear from them as well what they're thinking about, because I think that really is the issue of, can you build it and will they come, and how do you maintain it, and also being reasonable about what it costs, what the government is putting in, what development partners are putting in. Yes, and health workers' time. I'll just say one other thing about privacy, and I think this goes to the adolescent boy, issue. I think I sometimes have to be careful about my kind of gender assumptions, because in talking to boys, that was one of the things that came up, is they also wanted privacy. Both boys and girls said they wanted separate waiting rooms for these services. So just thank you for your question.
So we probably have time for 2 substantive questions, maybe 3 questions. So off you go.
Thank you. I'm Annika Knutsson from UNFPA. So thank you for the panel. I think you've highlighted behavioral change efforts from a systematic, from a community, from, social platform change perspective. And I think all of those are very important to get the changes we're looking for. I would like to hear from all of you how you foresee that taking a step forward to actually leverage adolescents and young people as agents of change themselves. What could lead to that in the efforts that you're now involved in? Because I think unless young people own their change themselves, it will not be sustainable. And maybe if you have some ideas on the education system and what role that plays, because I think the lack of critical thinking is a big piece here if we want real change. Thank you.
Thank you. Who'd like to take that first?
Well, I was just going to comment that I completely agree with you. Again, as I said, with our small, at least, experience at this level, at this stage, social media definitely creates a lot of engagement. I mean, just the scale of the number of youth who were interested and engaged. And I think in other fields from the social networks theory, we know that, yes, there are influencers online who you can take advantage of. I would say actually in marketing, they do a lot better, in these things. They find active people in the media whose word kind of has influence on other users, and they take advantage of actually these social media characteristics of influencer individuals to improve sales or start a new product and things like that. I think we have to do a much better job of taking advantage of those established models for addressing health and nutrition issues. So I agree with you completely, and I actually think that the knowledge is very well developed and it's out there. We have to tap into it and make sure that we use those agents of change. But I would say that definitely online platforms would be a good example of being, they have a lot of potential for doing that. Definitely.
Would either of you like to add just two quick points to that?
Just to add on to what Bandana said, of course, the youth of these days are always on their phones, and especially those who have access to, and you might be surprised about how access to phones is prominent even in Africa, in Asia, many places where we don't have access to other development programs, we do have access to phones, So by all means, let's use that platform to engage them, ensure that they have the data that they need, and empower them to speak up for themselves. But let's not forget also that sometimes the decision-making doesn't lie in their hands alone. Okay, so when they have money, they can't choose to buy snacks and so on when they go to schools and all of that. But when they come home, somebody else is making decisions as to what gets cooked or eaten in the household. So we need to engage the others also, the community systems, to strengthen them up and so on. And actually, World Vision is also looking at an initiative or a campaign to prevent violence in adolescents, which is tagged, "It Takes a World." It doesn't require only one organization. It doesn't require only one group. It doesn't require only one person. We all need to work together to ensure that the adolescents are protected, well cared for, they are empowered, and their voices are heard. So go on to World Vision site, wvi.org, and you can see some of the things that are being done to empower these.
Laura, would you permit me to get one more question in? All right, thank you.
Lee Waldorf, the Stephen Lewis Foundation. I direct this question to Bridget. Anyone, though, is fine. I was listening to what you were saying about the incredible impact you can have if you think about integrating grandmothers into your programming for adolescents. And that's absolutely what we've found as well. But the challenge I see right now, and this is what my question is about, is how do we get people over some sort of conceptual hurdle to be willing to fund work with grandmothers? We have, can you hear me?
No, not really.
You're pointing at me. You're pointing at me, and it means I need to talk louder.
Yeah, put it up.
This is good?
Great.
Okay, so I said you were totally right about grandmothers, and there's a huge impact if you integrate them into your programming. But there seems to be some kind of resistance to doing this, and I'm wondering what we can do about that, because the impact is massive. We have over 130 partners right now in 15 different countries. Every single one of them, in the context of fighting HIV/AIDS, has integrated grandmothers centrally into their programming, and they've also told us that they can't get a single other donor to support this work.
Yeah.
So can we, I mean, it's a question to you, but it's also a question to everybody else. Is this gender discrimination? Is it age discrimination? Is it age and gender discrimination? Why are we ignoring something that can be so important? That's my question, and an answer would be wonderful if you can solve this.
That's a very good point. I think you are very right. It's so hard to find funding to support programs like this because they are not the modern new technology that we have. You know, they are old, traditional. Why do we have to go there, you know? But we have evidence to show that if we do engage these grandmothers and these influential and powerful people who actually determine sometimes what is done to these girls, we can make a big change. My plea will be for donors and so on, when we do write proposals and stuff and include grandmother approach or grandmothers, enhancing culture, improving social norms and so on to be more acceptable, because the girls in these collectivist societies live in a system, you know, the health system is there, but it would meet them in a certain way. It won't go all the way. So we need to ensure that we fund all these programs, not just one. Social media is important. We want to fund those programs. We want to ensure that we have adolescent-friendly health spaces and so on. But we want to ensure that the community is also engaged. So please, let's put funding money on the table to ensure that this group are also engaged in unleashing the power for this adolescent girl.
Thank you, Bridget. And let's perhaps share the results that you found in your program, because that data will help us to build the pathways for impact that will generate the resources to support it. I've been given, I'm sorry, the word that we're at the end, but I would encourage you to please meet with the panelists immediately after to ask your question. Thank you very much to all of you, and many thanks to our panelists for sharing their experiences and their passions about this work.